Thank you very much for your introduction. My name is Waleed Albadi. I'm a cardiac surgeon at National Heart Center in Oman. So I will start talking about early and delayed intervention for post-infarctal VSR. I would like to start with the clinical case of 60-year-old male, smoker, diabetic, and hypercholesteremic, presented 12 hours after a chest pain. He was admitted at the hospital because of shortness of breath. Physical examination reveals there was a systolic murmur. ECG showed ST elevation in the inferior leads, and the patient had high troponin. Cardiogenic shock was diagnosed as cardiogenic shock, and intra-aortic balloon pump was inserted. Echography reveals that ejection fraction was 35% and 2.5 centimeter VSD in the inferior septal segment with moderate mitral regurgitation. Coronary angiogram reveals the LAD proximal had 80% stenosis, and marginal, second marginal with 75%, and PDA with acute occlusion. So now how can we manage this patient after initial stabilization? When can we start the intervention? Early or delayed intervention, and what type of intervention, surgery or transcatheter? If surgery, which technique we'll use? Post-infarctal ventricular septal rupture, they are critical complication of acute myocardial infarction. They can be presented with different presentation of mechanical complication. VSD, the most common one, acute mitral regurgitation, secondary to papillary muscle rupture, aneurysm or pseudoaneurysm, and free wall rupture. In this study, temporal trends and outcomes of mechanical complication in patients with acute myocardial infarction. It has been studied around 9 million patients in USA using NIS database. The patients divided in two groups. First group STEMI and second group non-STEMI. Mechanical complication, it's more in STEMI patients. And the most common complication, it was VSD on both groups. Talking about the mortality, it was the same, a high mortality in both groups. Another study, it was done using the database in the UK patients for patients from 1996 to 2018. Showed that the number of VSD repairs and the mortality, it was the same over the last 50 years. Here we can see there was no change in the mortality rate. It's around the same, it's always high. But if we saw for the repair of the patients who underwent the surgery, the patient who had operations less than 6 hours or less than 24 hours, they have higher mortality rates in comparison with the patients who had their surgeries or interventions after 1 day of presentation. Another study of total 6,000, this is a systematic review and meta-analysis of 41 studies. Divided the patient into two groups, periodic groups, from 1971 to 2000, and from 2001 to 2018, showed the mortality rate. It's the same all the time, despite the development in the medical and interventional treatment. And however, it showed also the odd ratio. The patients with IBAB, with the intra-aortic balloon pump, had more odds of mortalities. Also, the patient with RV dysfunction and emergency surgeries. It concluded also that the patient who had concomitant revascularization, they have better survival rates in comparison with the patient who had no revascularization. So what can we offer the patients as a mechanical circulatory support, which is a life-saving bridge to definitive surgical repair, especially in those patients with cardiogenic shock? Intra-aortic balloon pump is the most used one. ECMO and Impella, and we can also add transplantation or LVAD. Here, this study showed us that the patient who presented with a shock, they get more benefit with the intra-aortic balloon pump, while the patients who are unstable but who are not in shock, the survival rate is the same. For the ACLS, this study showed that the patient who had ACLS at the end of 16 days, they have the same mortality. There was no significant difference between both groups. The Impella has a rule also. In this study, they show that it's safe to use it in VSD, but the mortality rate is still high. So now, if we consider taking the patient to the surgery, what technique we can use? Infarct exclusion technique, that we put a patch at the septum and we take it out and we put two strips of platelet with the closure of the both lines. Double patch technique also, it's used it and showed its better results for less residual VSD. Back to our patient from the beginning. So our patient, it has been admitted with intra-aortic pump was inserted and treated medically, and he get a hemodynamic stability, no inotropes. So we discussed with the cardiologist team, and we removed the balloon, and the patient was discharged home. And after 1 month, we operated the patient for VSD closure plus CABG. Here is the video. So it's in the posterior wall. Here we open the left ventricle. We can see clearly the septum and the right ventricle. 2 layers of a patch will be inserted and stitched. Now we are taking the measurements. Making sure that the good bites with necrotic with fibrotic tissue, and here a closure with 2 Teflon strip. Another case here we can see also with the anterior VSD. I will make it faster.
Leave some volume in the heart. Abra, leave some volume in the heart. Leave volume.
Yes.
More. So you see. Okay, that's good. Thank you. Drain the heart.
Okay.
Abra.
Those patients also can present it with left ventricular aneurysm. We can exclude that with linear closure technique, but there's a disadvantage of this technique that we can reduce significantly the LV size. Another technique, patch ventriculoplasty technique, can be used with insertion of the patch over the fibrotic tissue and closure the rest of the left ventricle. Here I can show you another patient with severe and big aneurysm, anterior aneurysm. The patient had severe cardiomyopathy, and we considered to transplant him, and there was no donor for him, so we put the patient on LVAD. So we had the opening all the left ventricle. We can see how large is it. Here we inserted the cuff of the heartbeat 3, and here we can see the closure of the rest of the aneurysm, and here the heartbeat 3 in place. Another case also with the double patch technique that we used for a small left ventricular size, that we put another patch to close the left ventricle, and we inserted a heartbeat in the patch. In summary, those patients, they presented with in critical situation and in life-threatening situations that necessitate prompt action. The only thing that we can do for them to try with the mechanical circulatory support. In some cases, urgent surgery we have no way to avoid it. Multidisciplinary team discussion should be done, and to take care of that patient. Thank you very much.